Hello and welcome to the Clinical Liver Disease video series. CLD is an official digital learning platform of the NAFLD. My name is Fabian Rodas. I'm a transplant hepatologist at UT Health Science Center, San Antonio, Texas. I'm also the author of the NAFLD, a pre- and post-transplant conundrum. This review article highlights the many challenges patients with NAFLD must face once they enter this state of decompensation, where patients must contend not only with the disease itself, but also with a wide range of extrahepatic manifestations. These include glycemic control, cardiovascular disease, obesity, and sarcopenia. The conundrum arises when trying to balance the different treatment options, as weight loss may be effective for the treatment of obesity, but might not be suitable for the treatment of sarcopenia. Treatment for this condition often involves a combination of lifestyle changes, such as diet, exercise. Physical therapy and resistance training can help to improve muscle mass and strength, which can support weight loss and improve overall health. In terms of glycemic control, given the pathophysiological association among NAFLD, cardiovascular disease, type 2 diabetes, glucose-lower agents such as SGLT2 inhibitors or GLP-1 agonists may have an impact beyond glycemic control to directly improve liver disease activity, decrease liver fat, and may reduce cardiovascular risk. They are already proven to be effective for cardiovascular prevention in the setting of type 2 diabetes. They haven't been proved to do so in the setting of NAFLD. In a retrospective study of patients with cirrhosis and type 2 diabetes, initiators of GLP-1 agonists had lower rates of hepatic decompensation compared with DPP-4 inhibitors and sulfonylureas. Importantly, in the same study, the rates of decompensation were similar to individuals taking SGLT2 inhibitors. Now, GLP-1 agonists appear to be safe in decompensated liver disease and now recommended by the AASLD after recent updated guidance in the treatment algorithm of NAFLD. Surgically achieved weight loss in LT candidates also raises concern for precipitated liver decompensation, although gastric sleeve might be an option in highly selected patients without portal hypertension with decompensated liver disease in centers with expertise in bariatric surgery only. Now, the management of patients with NAFLD following liver transplantation can be complex, as many of the risk factors afflicting patients in the pre-transplant center may continue to contribute to poor outcomes after liver transplantation. For example, diabetes, prior LT, is a risk factor for decreased survival post-LT. Liver transplant recipients are at high risk of developing metabolic syndrome and cardiovascular disease as well. This highlights the importance of early screening for NAFLD using non-invasive biomarkers, FIB4, imaging techniques, MRE, transient elastography, and considering liver biopsy in patients who are adequately treated with immunosuppressive therapy but may have persistent elevation of transaminases in the setting of recent weight gain or poor glycemic control, particularly in the first year post-LT when rapid weight gain is gone. Finally, the immunosuppressive regimen should be tailored to mitigate the risk of developing risk factor for post-LT NAFLD. On behalf of the UT Health Science Center and the CLD team, I hope you find this additional video about NAFLD, a pre- and post-transplant conundrum, helpful. Thank you again for listening to this CLD video series, and for more information, please visit at www.cldlearning.com. Thank you very much.